Welcome back to the podcast. On today's episode, we're going to be talking about just super cool stuff that you learn when you are a curious clinician. So on today's episode, we have Dr. Anthony Breu, who is the Director of Resident Education at the VA Boston Healthcare System. He's the Director of the Consult Service and Assistant Professor of Medicine at Harvard. And most importantly, he is the co-host of the Curious Clinician podcast, the medical podcast that asks why. But before we get started, just going to have an introduction to the episode and a word from our sponsor. Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Dr. Breu, thanks so much for being on the show.
I'm super excited to be here.
You seem super excited to be here.
It's true. How could I not be?
So first, let's just talk about the origin of the show. What made you all get together and start the Curious Clinicians podcast?
So Avi Cooper, who is one of the co-hosts alongside me and Hannah Abrams, he and I had been posting on social media for a number of years, these why questions, these curiosity questions. And he approached me about starting a podcast as an extension of what we had already been doing on what was at the time known as Twitter. And I was enthusiastic about the idea, partly because I didn't want him to leave me in the dust. I was like, if you're going to be doing something like that, sign me up. And we realized we needed a third chair who would help with both diversity, because we were two guys, but also help to span the spectrum of ages, because he and I were both attending. So we wanted someone who was a little bit closer to the beginning of training. And so Hannah Abrams, who at the time was still in medical school, was really the perfect person because she had already established herself as pretty good in the world of podcasting, working largely with the Curbsiders. More than 5 years ago now, the three of us...
So did you poach? You poached one of the Curbsiders.
That is the correct word. We poached. Yeah, I'm trying to remember now. Did we ask permission? I don't think we did. I think we just said, Hannah, come join us as a co-host. You can't really... When you have the opportunity to go from producer to co-host, no one's going to be like, you're not allowed to do that. It's like
Physician podcasting tea, you heard it here first.
Exactly. If you're the offensive line coach and you're offered the head coach job, come on. If someone blocks that, that's not fair.
I think that just happened, right? Didn't that just happen?
Sure, it happens all the time, yeah. Oh, did that someone was blocked? Yeah.
No, I think someone just left the Chiefs for the Saints or something.
Yeah, that wouldn't surprise me at all.
Yeah.
The three of us were like, all right, let's do this thing. And it coincided with COVID. And so a lot of us were looking for an opportunity to teach in a different venue because a lot of the traditional forms of teaching kind of gone extinct for a period of time. You weren't allowed to talk to someone face to face. So it conspired around our mutual interest in asking why questions and the belief that it was time to turn this into an audio version because all we had done to that point was post these kinds of questions on social media.
That is a fantastic origin story. And then, so now there's the three of you, right? Asking why. But you were doing that before, but now you just decided to do it in a different medium. So then how do you pick topics? Because it sounds like there's so much possibility out there if that's the theme. It's kind of like with me and my theme, like just anything that's going to make a doctor a better version of themselves in and out of the exam room. There's so much we can cover. Same with you. How do you narrow it down?
The premise is going to sound overly simplistic, but if one of the three of us finds a question interesting and wants to know the answer, we assume that A, the other two co-hosts are going to find it interesting and want to know the answer. And more importantly, our audience is going to be interested and want to know the answer. And so there has never been a case where someone of the three of us has said, hey, I want to talk about X on the next show. And the other two have said, I'm not so sure about that. Instead, if there's a question that's offered that is too niche or we're not certain that it's going to have broad interest, we do work to hone it and potentially modify it slightly. And we do quite a bit of pre-recording, writing, and editing. But if someone thinks something is going to be interesting to them, we say, let's go with it.
So there's going to be enough enthusiasm because that person is also going to be the one that has to do the legwork of looking into it. So you're not going to say no to that. But at the same time, it sounds like you take the improv approach, which is yes and. So like when you're like, that's a really good idea. And this is how we can make sure that it appeals to a larger audience.
I think that's exactly right. And you said it correctly that if I'm interested in researching a topic, it's in some ways incumbent upon me to demonstrate why it's valuable and interesting to you as a listener. That doesn't always work perfectly, but as a starting point, I think it has worked quite well.
Yeah, I think if you've got enough enthusiasm about a topic, then that enthusiasm can be infectious. And then you can spin it in such a way that it becomes interesting. So it might seem boring on the surface, but your passion for it will then translate it into interest. So have you all covered anything yet that you think will be the next big thing in medicine? Is there something you've stumbled upon that's, wow, this is a hotbed of research that nobody's talking about and it's going to blow up soon? I'm just wondering if there's a company I should invest in that you guys have done the legwork on what they're doing.
If the answer to that question, like what should I invest in, were yes, I wouldn't tell you because I would be spending my dollars and I wouldn't want your listeners to be following suit. That having been said, on a recent episode, we talked about the barriers to the use of oral medications that are proteins. And the paradigm example that we talked about is insulin. The idea that for decades, nearly 100 years, we've had to inject insulin, that patients who have diabetes that requires insulin have to inject it, remains the case. It seems so antiquated. And it's like we can't have figured it out at this point. And you were talking decades, nearly a century later. And so we talked in that episode about the barriers to oral insulin and the oral administration of other proteins, whether it's the absorption, the degradation by proteases, or other things. We alluded to the idea that there may be mechanisms of delivery that will allow for the oral administration of medications like cyclosporine and insulin in the future. We're not quite there yet, but I do think that in the not too distant future, let's say next 10 years, we may be there. Is that the next big thing in medicine? Yeah, probably not. We already have GLP-1s and SGLT2s, but certainly if we were able to make that move, it would be a game changer for millions of people.
Yeah. I mean, it sounds similar, and correct me if I'm wrong, to like the issue with the mRNA vaccines, right? The issue was getting it into the cell. All right, we've got the technology. We can make this happen, but it's just going to sit outside the cell wall. How do we get it into the cell? So that was the major barrier. And so this sounds like a similar problem, right? How do we get it into circulation?
It's more of an engineering problem than a medical problem.
Interesting. So is there anything that you've learned on your show that you've then integrated into your practice, that you guys were like, whoa, maybe we need to do things a little differently? And actually, one of your most recent shows would be a good example of that, right? You talked about diabetic foot infections and how frequent Pseudomonas is, and yet you were treating for it, and yet do we really need to be treating empirically? What are some things that you've learned that have changed your practice?
Yeah, in that episode, which was led by Giancarlo Bonomo, who is a fourth leg of our stool, often behind the scenes as our producer, but has also been the co-host on a couple episodes. Fascinating discussion on what is it about diabetes that potentially predisposes to Pseudomonas? Is that just myth? Please go listen to it. To answer your question, I think the thing that hasn't changed my practice, but it has changed the way that I see a patient's trajectory is furosemide and this idea of it as being a vasodilator. In one of our earlier episodes, Avi talked about this idea that furosemide is not just a diuretic. It doesn't just cause natriuresis and diuresis. Instead, it is a dilator. And in the short term, before you see any urine production, you'll end up having a reduction in LV-EDP, and as a result of that, improvement in symptoms. And the reason that episode and that discussion, I have internalized it so much, is that it helped to answer something that I had observed so many times and couldn't previously have explained. And the example that I talk about on the episode where we go over this is when I was a third-year resident and I was doing a night float rotation. And so you're like the only guy in internal medicine. So, we're running around the hospital dealing with all these patients. And I had a guy who had acute pulmonary edema. And I went to the room and I said, all right, let's give him 40 of IV furosemide. And the nurse gives it. And I just stand there and I cross my arms and I look at the Foley bag and I just wait for the urine to come out. And like, I have nothing else I can do. I just gotta wait for the urine. But the guy started to feel better long before any urine was there. And I never understood why until we talked about it on the episode. And I found that to be such an enlightening moment.
Sorry, I'm an
That-
otolaryngologist, so you're going to have to take that next leap in thinking and explain it to me.
Yeah. Which part? Why does it
why he
cause
felt better. Why
venodilation?
did he felt better? Yeah.
The simple version is that furosemide doesn't just cause you to urinate. It also, through prostaglandin release, causes the veins in the body, largely the splanchnic area, so like the guts, to dilate. And so you have pooling of blood.
Got it. So there was a place for this fluid
That's
to go other than, so you made like a reservoir for, maybe
got
that's
it.
not the best word, but yeah,
It works.
for this fluid to go. Okay.
But it explained my lived experience,
Yeah.
and it explained these moments when I was so perplexed and frightened that has stuck with me so profoundly.
Is there anything that you've learned on the show that you think should be taught in medical school? Oh man, no, why this? Yeah.
The entire
Yes.
compendium.
Listen, that's my whole shtick. That's everything that we should have been learning, right? How to give a lecture, how to balance your budget.
I got one for you. So I don't know. I don't know when this inculcation begins, but there is at some point when you're a doctor that you're inculcated that if you see an elevated lactate, that means that the patient has hypoperfusion. For you as a surgeon, that maybe isn't what you're taught, but as an internist, lactate's elevated, hypoperfusion, and it's done.
Yeah.
And on one of the episodes, Avi, this is another Avi episode, he talks about this idea that anything that is a beta-2 agonist will lead to an increase in pyruvate production. That's going to overwhelm the ability for the pyruvate to turn into ATP, and so it's going to be shunted over to lactate.
Did you just reference the citric acid cycle?
I alluded to it, but I didn't specifically mention it.
No, but I'm sorry. The tagline is everything we should have been learning while we were memorizing Krebs cycle. And this is the first time someone has mentioned it on the show in over 400 episodes. So,
Yeah.
but you're using it. So thank you.
But it's important because
Yes.
if you make all this pyruvate and it can't go through the Krebs cycle, what's it going to do? It's going to turn into lactate. And so Avi talked about this idea that as a pulmonologist, he has seen cases where he's given a ton of albuterol, which of course activates beta-2 receptors. And it is known that if you give too much albuterol, you're going to generate a lactic acidosis. And so what I want people to learn in med school is the idea that if you see someone whose lactate is elevated, don't immediately say, it must be hypoperfusion, let's give him some IV fluids. Instead, step back and say, what is the differential for this? And probably the most important one that we see all the time is beta-2 activation from either endogenous epinephrine, exogenous epinephrine, or in many cases, things like albuterol.
Interesting. So actually, that was going to be the next question. What is maybe the most interesting thing you've learned on the show? May not be something that applies to the practice of medicine, right? Like before the show, we were talking about the fact that lobsters don't age. Right?
No, they don't.
To me, that's interesting. Or that there are animals on the earth, not marine animals. So that marine animals are the ones that sometimes live the longest, that are age so slowly or not at all that they've been around for 10,000 years. So that was something that I found super interesting. So what are some of your most interesting facts?
So the lobster episode is packed with facts like that. And I'll offer another episode that is animal-based that I found absolutely fascinating. And it's one where Hannah reviewed the idea that elephants just don't seem to get cancer. And they're not alone. Like blue whales and other large creatures seemingly don't get cancer at nearly the same rate as humans. And she talked in that episode about how that is a paradox. And it's actually called Peto's paradox after Richard Peto, who identified it in the 1970s. And you would imagine that a creature that has orders of magnitude more cells than humans, elephants, blue whales, should get orders of magnitude more cancer because there's just greater opportunities for tumors to form. But that doesn't necessarily happen, and that's the Peto's paradox. And in the case of elephants...
Hold on, I got to pause you here, because the question would be, how do we know if elephants do or do not get cancer? Because are we out there doing elephant colonoscopies, right?
We are.
It's what the curious clinicians do as their side gig.
That's what Hannah does. She's the oncologist of the trio. No, so it's funny that you mentioned that. We do mention on the episode the barrier to great understanding, because we're not doing autopsies on tons of elephants and blue whales. But the best we understand it, the rate of cancer in elephants is less than 5%, whereas the rate of cancer in, say, a human is on the order of 15 to 20 and even maybe potentially higher, depending on the studies you look at. And obviously, as you age, the rate goes up dramatically. So, yeah, are we 100% certain that elephants have less cancer? No, but I think there's some scientist out there who's published a paper to say, yeah, it's less than 5%. And the reason relates to a gene and a protein that I think many people have heard of. The tumor suppressor protein is P53 and the gene is TP53. And it turns out that elephants have something like 20 copies of this thing. And this has really placed them in the position of just wiping out cancer cells as they emerge, which protects them from the scourges of, I guess, you're worried about their colon having cancer, but certainly other cancers as well.
It was just maybe the grossest image I could think of relating to elephants.
Doing a colonoscopy on a whale?
Exactly. Yeah. Like looking in their mouth, look at oral cavity cancer. Are they getting tonsil cancer? Are they getting floor of mouth cancer? No, you got to look in their elephantuchus for cancer. So is there anything that you learned from the show that you've ended up applying to your own life? That there's what you can apply to your practice, right, when you're treating patients. But is there anything that you've ended up applying to your own life?
There's a number of episodes that have covered food-related topics, and it would be unsurprising that some of those topics don't seep into our day-to-day lives. So we've talked about why onions make you cry when you cut them, why the Thanksgiving meal causes a food coma, tastes like soap, why umami tastes so good, a bunch of different things. The one that I'll offer for your audience is the why onions make you cry, because I do think it can potentially lead to a change in practice, though I don't know that you necessarily have to have listened to our episode to change what you're doing. But one of the fascinating things I learned on that episode was the idea that what's happening is you're cutting this onion and you're releasing all these proteins. And myriad enzymatic reactions are happening after that. And they're actually happening in the air, like in front of your eyes. So it's not like you're cutting the onion and you're releasing some noxious compound that's making you cry. You're cutting the onion. All this reaction is occurring. Multiple reactions are occurring, which, by the way, is why it's delayed. You don't cut the onion and immediately cry. It takes some time for these reactions to occur. They're happening in front of your eyeballs, and then this molecule called propane thiol S oxide gets into your eye and causes you to cry. So what should your audience do? And what have I potentially done?
Swim goggles.
So goggles, or even just contact lenses.
Oh.
And I wear glasses, as you can see, Brad, but your audience can't. But my wife wears contacts. And so she is the onion cutter of the family. And she doesn't cry nearly as much because that propane thiol S oxide that's generated in the air in front of her doesn't have as easy access to her cornea, which, I don't know, I find that kind of cool.
So it's the receptors in the cornea that's the problem. So it's not happening in the sclera or the conjunctiva. It's happening in the cornea.
Best I understand, it's corneal irritation that's leading to the crying.
Huh. Amazing. That's one of the benefits of podcasting is you have questions that you want to get answers to. And you want to share that with the world. So I'm just going to pitch the Doctor Podcast Network, because if you think that you can do what I do, you're probably right. And so you have every reason to do that. It gives you a venue for getting cool and interesting people in front of you and getting interesting questions answered. So that
without elephant colonoscopies, learn about wearing contacts while cutting onions, you've got it all.
Exactly. So just a plug for drpodcastnetwork.co. Click on the link to join. But we're not done yet, because I have one more question for you. And in the age that we're in right now, the age of pseudoscience and misinformation. So is there anything that you've learned on the show that sounds like pseudoscience, but isn't? That you're like, there's no way that's true. And then you found out, wait a second, it is.
Yes. So I live in New England, the land of ticks. And many of your listeners have probably heard this, but I think the first time I heard it, they heard it, probably said, this can't be right. But if you get bitten by a tick, you can then become allergic to meat.
Alpha-gal, yes. I'm on Long Island. We've got alpha-gal on Long Island, yeah.
Exactly. And so we talked about it in the episode. And one of the really fascinating things about alpha-gal that we talk about in the episode, and we actually talk about in another episode about valves and the fact that you don't need immunosuppression when you get a valve from a pig, is the idea that the major barrier to xenotransplantation, so taking a pig heart and putting it into me, is alpha-gal. So alpha-gal from ticks causes a meat allergy, but also is a barrier to xenotransplantation beyond simply putting in a mitral valve or an aortic valve. If you said to the random person, be careful if you go up to Martha's Vineyard, if you get bitten by a tick, you won't be able to eat beef after that, I would say many of them would be like, that's bunk, that's crazy. Of course that can't possibly be true, but it is.
Yeah, amazing. If anyone wants to have a taste of the amazing content that they have on the Curious Clinicians podcast, Dr. Breu, thank you for making all this interesting stuff so accessible to the rest of us, producing amazing content and taking the time to be the guest on the show. So if people want to find you, they want to find the show, where can they do that?
We're available on nearly all podcast hosting platforms at The Curious Clinicians. We also have a Substack, a YouTube channel. If you just type into Google The Curious Clinicians, you'll be sure to find us.
Excellent. Thanks again for your time.
It was great being here.
Thanks for listening. So please share it or like it or comment on a social media post or write us a 5-star review. Thank us again for listening to The Physician's Guide to Doctoring.